Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
This program is presented by Medscape Education Global.
Welcome, I'm Volkmar Müller, gynecologist at the University Medical Center Hamburg-Eppendorf, and I welcome you to the Medscape program covering not only San Antonio but also emergent data of the future of advanced breast cancer care. So a deep dive into novel data and also many of the emergent therapies. And joining me for discussion is a medical oncologist colleague from another country, from Great Britain. I'll let her introduce herself, Judy. So welcome.
Thank you. So my name's Judy King. I'm a consultant medical oncologist based at the Royal Free Hospital in London, UK. So yes, looking forward to our discussion. So we've seen some key data and updates on metastatic breast cancer from the recent San Antonio meeting. But actually, it's been a busy year with a wealth of data throughout all of 2024. In this program, we will spotlight data from San Antonio, but we'll also draw on the rest of the year's data to give it a little bit more context. So if we start with ER positive or hormone receptor positive metastatic breast cancer, I think I'm going to hand over at this point to you, Volkmar, to present the data that we heard from the PADMA study.
Yeah, PADMA was one of the honest trials, I think, that really didn't change practice, but I think it encourages clinical practice today. So for hormone receptor positive, HER2 negative disease, for almost all patients, I think in our clinical practice today, CDK4/6 inhibitors combined with endocrine therapy are the standard of care. But still, I don't know, and certainly something we could discuss afterwards. Sometimes in the tumor board, we have the discussion if this certain patient is not a candidate for chemotherapy, because we have all sometimes in mind, I believe, chemotherapy might be better in some ways. And in this context, I think it's important to have another trial in the first-line setting comparing chemotherapy with endocrine-based therapy. So what PADMA did, it randomized patients to receive either endocrine therapy plus palbociclib compared to chemotherapy induction and then followed by endocrine maintenance therapy. So it was in the setting of hormone receptor positive, HER2 negative breast cancer, again, a small trial of 150 patients, and it was presented in a general session in San Antonio, so I think it's considered as an important trial. And finally, the endpoint was time to treatment failure, and it was positive for endocrine-based therapy. So the time to treatment failure with palbociclib plus endocrine therapy compared to chemotherapy. Huge advantage for endocrine-based therapy, and I think this is in line, we're going to discuss that probably with other trials. For overall survival data were not mature, so I think there's no different to expect at the moment. And adverse events, more neutropenia with palbociclib, but we all know that this is easy to handle and not comparable to side effects of chemotherapy. So in general, a better tolerated treatment. And from this trial that was not presented this part, but there's a huge program for quality of life assessments, like time patients move, so how many often patients come to the hospital. So I think that was a positive trial for endocrine-based therapy, confirming what we already do. And there's a lot of data to come from this trial and from others also comparing quality of life, which we would expect is better with endocrine-based therapy. So I don't know if there's, from your side, Judy, any implications for clinical practice, but what do you think about this trial and our clinical practice for this situation?
Yeah, I mean, I think it's really important, actually. We've known for some time, this often happens that by the time a trial reads out, the question that they're answering has sort of already been answered. But, a lot of people in recent years, because of other trials and survival data in the metastatic setting, have moved a bit away from palbociclib and maybe more towards ribociclib, for example. We know also from the Right Choice study, which looked at patients in this setting, first line versus chemo, and quite sort of significant levels of liver mets, liver dysfunction, the kind of patients that we used to historically give chemotherapy to. So we already had this data with ribociclib, but there are a proportion of patients that can't tolerate ribociclib or for whatever reason you need to switch. And so to have confirmatory data with palbociclib, I think is really important. It shouldn't be practice changing because everybody should already know that we should be treating the biology and should be treating these patients with the CDK4/6 inhibitor in the first line in nearly every setting. But we also know that not everybody does, and old habits die hard, and a lot of people still have been reaching for the chemotherapy. And so that inertia has been slow to change. And I hope that this will push the stragglers again in the right direction of endocrine plus CDK for first line, all patients, even the high risk ones.
Yeah, although after the presentation, there was some discussion, as far as I remember, about there might be some patients that need chemotherapy. And the question, of course, is visceral crisis, what's the definition? So I still believe we have some patients, but for the vast majority, I think we do it right, and it's encouraging. And as you said, we have another treatment option with good evidence now for first-line treatment.
Yeah, I mean, the visceral crisis question comes up time and time again, but actually, if you think about the number of patients that you've treated in visceral crisis versus the vast majority who have, extensive liver mets perhaps and sort of slightly elevated transaminases, but stably so, the visceral crisis patients is such a small proportion that and maybe we don't really have the data there, but for the vast majority, I think this data holds.
Completely agree. I think that was, consensus in the auditorium, I would say. So, yeah. But in the end, patients might need chemotherapy after one or several lines, mostly after several lines of endocrine treatment. And I think we have also seen data in the 24 about trastuzumab deruxtecan in first-line treatment. So it was DESTINY-Breast06 that was first presented at ASCO 2024. And then there was an update in San Antonio about DESTINY-Breast06. So just to remind you, it was a trial that examined trastuzumab deruxtecan in hormone receptor-positive breast cancer, not overexpressing HER2. So there was HER2 low, which we have already an approval based on DESTINY-Breast04. But it was also a cohort of patients that had HER2 ultra low, and it was first line after failure of endocrine therapy. And as far it is not approved, as we record this in the first line setting, but we all wonder, I think, if there are patients that really benefit more from T-DXd in the first line setting or not. And that was data that was presented in San Antonio. So a subgroup analysis based on pre-treatment, mainly of patients. So it was several analyses were shown. I think a lot of analyses actually, a little bit confusing at the first glance for me, to be honest. But mainly it was the duration of endocrine treatment on CDK4/6 inhibitor that was divided into 3 groups. And also it was divided into primary and secondary endocrine resistance. And for me, the conclusion was actually there's not a group which doesn't benefit from trastuzumab deruxtecan compared to standard of treatment of physician's choice. So what's your thought about that, Judy?
Yeah, I mean, I think we'll talk about it a bit more in a minute when we talk about the EMBER study, but this question of what to do after first-line endocrine CDK is becoming a much more complicated area. And certainly T-DXd is a drug that will, by and large, HER2 low is ER positive HER2 low. So I think it is important. It's important to know. I think certainly in the UK, this is not a drug that we have access to, so it's not going to be immediately practice changing at the moment. But I think interesting data and useful to know that this is a drug that works across the subgroups.
I think it might impact the future practice. But as you said, we have access to T-DXd in HER2 low, hormone receptor positive and triple negative disease after previous treatment, and it's not approved, I think, nowhere in the European Union as first-line treatment. Probably one of the options, and if patients need chemotherapy, it might be the better option compared to standard treatment as it was used in the trial. So I think that is our part on chemotherapy, but there's some more things now after CDK4/6 inhibitors, and I think most patients, or many patients, will receive a second line of endocrine-based therapy. And from the trials, we have seen that endocrine monotherapy we have currently available, so fulvestrant as monotherapy, is not very effective in some settings or many settings in many clinical trials. And we had approval of several drugs over the last 2 years. So it was for ESR1 mutated patients, elacestrant after CDK4/6 inhibitors. And it was also capivasertib that was approved based on Capitello in patients that have alterations in the PI3 kinase signaling P10 AKT. So it's an AKT inhibitor, capivasertib, combined with fulvestrant. And we had data from Maintain that examined the treatment with CDK4/6 inhibitor after CDK4/6 inhibitor, just changing the CDK4/6 inhibitor in most patients or maintaining it and changing the endocrine therapy. But here in San Antonio, we saw also interesting data of a new compound, and that's something maybe, Judy, you want to tell us about the EMBER-3 trial.
Yeah, I mean, I think we have, for some time now, the congresses have been talking about the oral SERDs in development, and we've been watching them all move through the phase 1, 2, 3. And we all know that there's more than one oral SERD. They're not all the same, slightly different toxicity profiles and so on. But San Antonio, it was time for imlunestrant. And so this was a 3-arm study. So essentially this was second line, so after first-line endocrine therapy. And I would say about 2/3 of patients had a first-line CDK4/6 inhibitor. Initially, the arms were imlunestrant versus standard of care endocrine therapy, and the majority of those patients received fulvestrant. So it was basically a fulvestrant versus oral SERD trial. And then they added a third arm, which was the imlunestrant, so the oral SERD plus abemaciclib. So slightly complicated because they did 2 different things within the study. But essentially, the primary endpoint was, first of all, the oral SERD versus standard of care endocrine therapy in the ESR1 mutant population. And they demonstrated a statistically significant difference. So the median progression-free survival improved from 3.8 to 5.5 months. And that's very much in keeping with data that we've seen with other oral SERDs in exactly this setting. The other thing that they looked at was the imlunestrant plus abemaciclib combination, which was proven to be safe. And they compared that to the oral SERD and showed that in all comers, there was an improvement in progression-free survival, sort of 5.5 versus 9.4 months with a hazard ratio of 0.57. So that's all well and good, but I think when it came to the sort of the ongoing discussion about where this combination might potentially fit, there was a lot of discussion about the control arms, because as you were just very much describing just now, what is the real control arm after first-line CDK4/6 inhibitors? I don't think it would standardly be imlunestrant in all comers. As you've said, it could have been fulvestrant and capivasertib. It could have been a CDK switch combination. And what you've really got here in the imlunestrant abemaciclib is, if you bear in mind that 60% of those patients that had a CDK4/6 inhibitor first line, you've kind of got an abemaciclib switch in 60% of the patients here. So for me, the data was a little bit difficult to tease out and sort of say, where are we going to put this combination in the future? Certainly with the overall survival wasn't mature, but was looking like there was a positive signal there. But I think there were a couple of points, and if anyone has access to the slides, the discussant was really interesting on this point. I think one of the things that we need to think about with the oral SERDs is where they sit. We need to think about that there are differences between the different drugs in terms of the toxicity, and particularly with this one, there didn't appear to be the bradycardia or the visual side effects that we've seen with some of the other drugs. But We don't know how the imlunestrant abemaciclib combination would have done with just fulvestrant abemaciclib. One assumes that imlunestrant would be better because of the better bioavailability of the oral drugs, but we don't have that data. We do have the fulvestrant capi data. I mean, I have to say, in summary, I found it interesting but difficult to say that it was an entirely practice changing. Now, Voltmar, what did you think?
Well, I'm happy that also you not sure what to implement that in the next year, because I think I found it a little bit confusing. So it's obviously that no trial will answer all these questions you have addressed, because we have now, as we already mentioned, so many options, which is good on one hand. On the other hand, it's a little bit confusing. And if you look at the slide that was put up in the discussion, there's so many lines and options. We have to sort it out. There's going to be a few more trials combining news, anti-estrogen SERDs or other PROTACs in combination with the CDK4/6 inhibitors, also in first-line therapy. So we're going to find out if it's really, as you already mentioned, Judy, if it's more the CDK4/6 inhibitor, if really a new endocrine option adds so much to the efficacy of the CDK4/6 inhibitor. And this will be also the, I think, important question for the first-line treatment, which might also change from aromatase inhibitors or fulvestrant to new compounds. This is going to be, of course, maybe also impact the first-line treatment. So far, I believe we don't know. We have encouraging data. We have a new compound that is very effective, more effective than fulvestrant, an oral option, which is also nice for many patients. And it seems to be well tolerated, which I think is also of great importance in all the context of things we discuss. Things have to be well tolerated for patients. It's a palliative setting in the end. So there's a lot of things going on, and I think it's very interesting and although confusing, but we're going to manage that, I believe.
I mean, I was actually speaking to a colleague who sort of said that they had been surprised because, you know, we do know that compliance is an issue. And at least with fulvestrant, you know that the drug has been given. Whereas with like more and more tablets, the sort of tablet burden over time, I mean, clearly compliance is better in the metastatic setting. But the data here was that the oral combination, I mean, obviously we think that people don't want to have an injection, but you do slightly worry about people taking all of these tablets. I think we're going to have to wait and see. And I think it will be a question of, you know, for example, the fulvestrant capivasertib combination, that will turn into data on the oral SERD capivasertib combination. So I think, you know, this data that we currently have is confusing enough, but it's going to get more confusing because, as you say, really interesting stuff coming through with the PROTACs. I think that's the other group of drugs that a lot of people are going to be looking out for in the future. So shall we move to the next section? I'll hand back over to you for the HER2-positive updates.
HER2-positive disease, I think, has changed for many years, and was I think was the motor or the start of revolution in metastatic disease, because with trastuzumab we had a change in therapy options. So first-line treatment, on the other hand, hasn't changed for many years. It's still trastuzumab, pertuzumab, plus a taxane. And I think the Cleopatra trial was the approval trial for that, and it used docetaxel. And if you remember, in this trial, it was not allowed to do, after the stop of chemotherapy, to just put patients on an endocrine maintenance therapy. So now I think we all do that. Hormone receptor positive, HER2 positive patients, so-called triple positive patients, usually get an endocrine maintenance. But I think we have seen something practice changing now in San Antonio. At least for me, it was. Curious for your judgment, Judy. So what was the trial we saw?
So yes, I think the really interesting data, and one of the things that most people would say was their big take home, was the Patina study. So this was looking at that question of endocrine maintenance therapy after induction with the DTP Cleopatra regime. So patients who'd had their at least sort of 6 cycles of DTP would then go on to therapy maintenance plus or minus palbociclib. And one of the important things to notice here is that firstly, the PFS in this ER positive group is going to be different because firstly, it's ER positive, HER2 positive breast cancer. Secondly, there is that difference with Cleopatra because all of these patients got endocrine therapy. So that pushed the PFS up for for all patients. And then thirdly, the important point was anyone that had sort of primary failure and didn't respond to DTP in those first 6 cycles, or anyone who responded and progressed very quickly, did not get onto the maintenance phase. And so a slightly better prognostic group was selected for this study. And almost for that reason, they had to follow these patients up for a very long time. So this data is a long time coming, but was worth waiting for. So the primary endpoint of progression-free survival demonstrated a statistically significant difference of 29 versus 44 months in favor of the palbociclib endocrine combination, which I think is very difficult to ignore. And when they looked across the subgroups, they couldn't see a great deal of difference. It does appear that everybody does benefit, and there is a suggestion that the overall survival will also be positive as well, although we're going to have to wait even longer to see that. In terms of toxicity, I think we all know palbociclib well, so there will be additional toxicity, but I don't think it's anything that we could struggle to manage medically, although I was discussing with a colleague just yesterday who was saying, well, the burden on the clinic and the number of additional blood tests and so on that patients would have to go through is not to be sniffed at, because it really would be for a very long time. I think the important thing with this study is that certainly when I was a junior doctor and when I was training, HER2 positive breast cancer was very much, this is the driver, this is important, this is what you need to focus on. And the initial studies did not really focus on the endocrine partner or, thinking about those sort of the ER pathway as a resistance mechanism. And this trial has definitely pushed our thinking very much in a different way again. And I think it'll be really interesting when we think about the other studies that we've got. I've been in a number of meetings where people were setting up studies either in combination with this kind of maintenance therapy. And I do remember saying, we're going to have to wait absolutely ages to see this data, and thinking, God, that's going to be a really expensive study to run. But, they've done it and it was worth it. But there are other similar studies coming on their heels. Volkmar, what was your take home?
I think it was practice changing. And I think it illustrates a little bit that we've missed an opportunity because it took quite a while. So Cleopatra was presented more than 10 years ago, as far as I remember. And it took us a little while. We presented also, Wolfgang Janni presented a German trial. It was called Detect 5, that was comparing endocrine induction or endocrine therapy alone with trastuzumab, pertuzumab. So it left out the chemotherapy. And just in brief, I think there's no indication that chemotherapy is better. And it might be possible that we don't need chemotherapy induction for some of our patients with triple-positive breast cancer. That's one part, so de-escalation, and the other part might be there's Destiny Breast 09 coming out, probably 25 read out, that is using TDXD as first-line treatment. So we have also here something between escalation and de-escalation where we don't know where we will end up. I think we have to understand better which patients really benefit from endocrine-based therapy also in HER2-positive disease. So that's my take home from that.
I know there's a number of different trials with the sort of this trastuzumab, pertuzumab, plus or minus an oral SERD versus the endocrine therapy, or addition of tucatinib is another one of the HER2 CLIMB studies. I think it's 05. But then there's also, as you absolutely rightly say, with the TDXD studies, firstly, we're going to have the DB09 in the first line. There's an expectation, certainly from the clinical community, that this will be a positive study. There's also next year going to be the readout from the TDXD in the earlier lines of treatment, so the neoadjuvant and the adjuvant. And, what do we do then with these patients who have had access to those drugs earlier? Will that still be relevant? I think there are some countries where people have been talking about, TDXD and then going back onto a sort of maintenance therapy, which certainly in the UK we wouldn't be allowed to do for reimbursement reasons. So I think it's just opening up to a whole bigger set of questions that I still don't know the answer to.
Yeah, and I forgot one trial. This is HER2 CLIMB 05, which also will be probably read out because recruitment is finished also mid of 24, and it's using, after Cleopatra induction, tucatinib. So there's a lot of options coming up, and I hope many positive trials, which make it even more difficult.
A lot of options, and I think when we're thinking about the sort of the brain mets as a site of recurrence, I think that that's something that we need to be, because the oral SERDs, whether there's brain penetrance, and then also with the CDK4/6 inhibitors, CNS penetrance. I think there's lots of really interesting questions that we can start to unpick hopefully next year.
For brain mets, just in brief, there was Destiny Breast 12 that was presented, and there was an update on the data of trastuzumab deruxtecan in HER2-positive metastatic disease presenting with brain metastasis, and it was examined the quality of life. And we had seen data on the efficacy of the drug in brain met patients, also in brain met patients, was not only brain met patients, at ESMO 24. And I think that was also impressive data, because I think that really illustrates what we have achieved now with also systemic therapy that is effective in the brain, as so many patients will develop brain metastasis. And here was quality of life data that was really also illustrating, I think, that for many patients, brain mets do not seem to limit the quality of life so much. That was my take home from Destiny Breast 12 update that was presented in San Antonio at the poster spotlight session. So that was our part for HER2-positive disease. Did I miss anything? Anything to add?
I think that's enough to be getting on with.
Okay. There's a lot of trials that we already mentioned coming up also for HER2-directed therapies in the early settings. So tucatinib and also TDXD are examined in early breast cancer, neoadjuvant, post-neoadjuvant treatment settings. And both compounds, we already mentioned the trials, Destiny Breast 09 for first-line setting of trastuzumab deruxtecan, and Destiny Breast HER2CLIMB-05 as tucatinib as maintenance. So this is going to change our treatment landscape, and we don't know where we're going there, but a lot of hope for HER2-positive disease. So finally, we thought we're going to briefly also address triple-negative disease. I think there was not so much new in San Antonio, and I think also my feeling not during the year. So just we have had some major progress during the last years with checkpoint inhibitors as first-line therapy in PD-L1 positive patients, with sacituzumab govitecan and second-line treatment as ADC in triple-negative disease, and also in the option of trastuzumab deruxtecan in HER2-low patients with triple-negative disease as a treatment mostly after SG, I would say. So there's been a lot of progress, not to forget the PARP inhibitors in BRCA-mutated patients, but I think not so much new data so far in San Antonio, at least. What was your perception, Judy?
Yeah, I mean, I think speaking to colleagues, I think all of us have, been somewhat blown away by the changes in HER2-positive breast cancer just in the last couple of years. And then with your hormone receptor positive, as we were saying earlier, we're almost an embarrassment of riches. We're trying to figure out where they all fit in, but we've got so many options and so many combinations and sequences to think about. Triple negative is still that poor relation. It's still the unmet need. It's still the area where, patients do very badly. We don't have lots of options, and there wasn't a huge amount of data this year. We have high hopes for the antibody drug conjugates. We have lots of questions about ADC sequencing. There will be data coming out next year with dato-deruxtecan for the PD-L1 negatives, and also I think we're waiting for the combination data with immunotherapy for the PD-L1 positive, perhaps, but still hoping to see the next big thing for triple negative.
Yeah, I think we've already have so many improvements also with early breast cancer and triple negative patients. So it's also some time to have a little bit less new data. I think that's also okay. And as you said, there's going to be a lot of things to come. So that's it from my side. Thanks for watching us.
Yes, and thank you from me as well to everyone who's been watching at home and participating in this activity. If I could just remind everyone, please do continue on to answer the questions that follow and complete the evaluation. That'll be really helpful as we're sort of planning future activities.
This program was presented by Medscape Education Global.